So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the localization assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neonatology Forum, Gujarat chapter. And the focus of today's session is case presentation on DSD with dysplastic kidney. Now, without wasting any further delay, let's begin today's session, for which I would like to invite Dr. Kunal Ahiya, sir, the Honorable Secretary of NNF Gujarat chapter, to start the event today with his enlightening words and for the further coordination. So the right is all yours, sir. Please proceed.
Thank you so much, Ritu. So today we are continuing with our neonatal Pathshala series. Today we have a very interesting case on DSD with dysplastic kidney. For that we have Dr. Mitesh Chaudhary, who is the resident at Jamnagar Medical College. As his mentor, we have Dr. Maulik Shah, sir. He needs no introduction. Sir is an associate professor of pediatrics at Jamnagar Medical College, MP Shah Medical College. Sir has a lot of interest in making videos, and sir may have made more than 200 educational videos for medical fraternity, which have covered more than 9 million views. And sir has done his MBBS, MD, and sir has also done his neonatology fellowship from Manipal Hospital, Bangalore. Thank you so much, sir, for mentoring this case. And for an expert today, we have Dr. Chetan Dave, who is a consultant pediatrician and adolescent endocrinologist, director at Center for Pediatric Endocrinology and Diabetes at Rajkot. Is our star endocrinologist with us. Chetan has many laureates with him. He has done his fellowship from Kanpur and also from Cleveland and Liverpool, UK. He has many publications and paper presentations. So welcome, Dr. Chetan. Before starting the session, I would request Shwetal Bhatt Madam to say a few words. She is our president of Gujarat State NNF.
Thank you so much, Dr. Kunal. I'm really glad to have Jamnagar team with us presenting an interesting case. And I'm really fortunate to have you as a secretary. We are marathon every Wednesday. We are doing this neonatal Pathshala. And just one coming weekend with the Diwali week Wednesday, we'll have one break. Otherwise, we are doing this Pathshala continuously because of Dr. Kunal's efforts. And I welcome Dr. Chetan. Glad to have you on this platform again and sharing your expertise. Thank you so much. We'll hand over to the presenter.
Mitesh, you can share your slides now.
Yes, sir. Good afternoon, all. Myself, Dr. Mitesh Chaudhary, third year resident doctor, Jamnagar, and we prepared newborn case with Dr. Mansi Bhavsar under the guidance of Dr. Maulik Shah, associate professor of our college. A case of full-term newborn presenting at first hour of life. Normal delivery at
Voice is not hearing.
a case of full-term normal. A case of full-term newborn presented at first hour of life. Normal vaginal delivery on 9th October 2024 at 12:40 p.m. at GG Hospital, Jamnagar. Gestational age was 39 weeks. Birth weight was 3.8 kg. Informant was mother. Born at non-consanguineous marriage. No history of any hereditary disease or any major illness in family.
So what was the complaint? Maybe you should write in the first slide.
Mother was 29-year-old, third gravida. Last menstrual period was 12 January 2024. Expected date of delivery is 18 October 2024. Mother blood group was AB positive. No past history of hospitalization, hypertension, gestational diabetes, mellitus, any drug exposure or smoking. On general examination of mother, no abnormality noted. Family history. Pedigree chart showing mother was 29 or 29 years old. Father was 30-year-old. First child was expired at 1.5 year. And because of conversions according to the mother. Second was third year male child, full-term normal vaginal delivery, no history of NICU stay. And history of infertility in maternal aunt, some medication last taking 3 years. Documents was not available. First trimestral history, regular visit at hospital, tested negative for serological marker, HIV, HBs, antigen, and VDRL. Folic acid was taken regularly. No history of fever, hypertension, diabetes mellitus, hypothyroidism, radiation exposure. Drug history. HP was 12.9 gram. First USC at 10th week. Report was not available. Second trimester history. Fetal movement noted at 18 weeks. Anomaly scan was done 19 weeks, which was normal. Both iron and calcium tablet were taken regularly along with folic acid. 2 days of TD was taken. Third trimester, no history of radiation exposure, any teratogenic drug use, hypertension, diabetes in pregnancy, no history of fever, burning, maturation, discharge per vagina. Routine scan at 28 weeker, like was adequate, a brief presentation. No hospital visit after 28 weeks. Mother was present in emergency with lower abdominal pain on 9th October 2024 at 11:20 a.m. Portable cardiotograph was revealed fetal distress with tachycardia, 170 beat per minute. Maternal BP was 150 by 100 mmHg. Cardiograph plotted and continue cardiotograph monitoring was done. Labor progress and deliver 1.1.5 hours. Child was delivered 9th October 12:40 p.m. Birth weight is 3.9 kg. Liquor meconium stain. Presentation is vertex. Baby was vigorous, had tachypnea, so shifted to the NICU. Baby was received with following vitals. Pulse rate was 150 per minute. Good peripheral pulse volume. Aspirated was 72 per minute. Subcostal retraction present. SPT was 80 to 82% in all volume. Capillary filling time was less than 3 seconds. RBS was 89 milligram per deciliter. Mean blood pressure was 56 mmHg. Down Vidyasagar score was 3. There was ambiguous genitalia. In Downey score, there is a feature of air entry, cyanosis of lips and mucosa, expiratory grunting, retraction present, and respiratory present. So we count Downey score as 3 out of 10, sir. Patient was given IV fluid and oxygen by nasal pumps. Due to the worsening of respiratory distress, baby put on HFNC, high frequency nasal cannula at third hour of life. At third of life, Downey's Vidyasagar score was 6. X-ray showing well exposed centralized X-ray showing a right lower patchy opacity was present. On examination of external genitalia, there was no palpable gonads. Genital and the urinary opening was same. Enlargement of clitoris size around 10 mm and posterior labius product fusion was present. Respiration gradually improved over 18 hours. Rise to feeding started at 2 ml per kg, which was gradually increased. At 24 hours, sepsis screen was sent. In sepsis screen, there is a HPO 17 gram per deciliter, and ANC count was 300 and 3000. ANC count level 3033. CRP was 21.5. And there is a serum create was 2.2 milligram per deciliter. And sodium also 139.3 milligram per liter. Potassium was 6.9 milligram per liter. Urine output at 1 hour, first 24 hours, 0.5 ml per kg per hour. Considering US first time antibiotic was started, patient was tolerating full feed. After that, vital was taken. Temperature was 101.3 Fahrenheit. Respirator was 64 per minute. Heart rate was 154 per beat minute. SpO2 is 97% on HFNC with F5 to 35. There is no cyanosis or grunting, no detection or CRT less than 3 seconds. At 72 hours of patient put on HFNC, F5 was 30%. Flow rate was 6 liter per minute. Karyotyping of a patient was sent. Tachypnea is present. R was 64 per minute. BP was 72 by 50. Mean pressure was 57 mmHg. RBS was normal. Urine output of last 20 was 0.3 ml per kg per hour. So we have started, and sodium was 162.6 milligram per liter. So we have started half NS, D5 half NS started. Antibiotic in renal dress and FENA was planned. There is a 17 OHP and which was 14.92 nanogram per ml, and serum creatinine also 5.1 milligram per deciliter, and which was gradually increased. We have done USG abdomen QB. So in USG, increase ecotexture of bilateral kidney with multiple cysts in bilateral kidney. Largest size was 0.7 into 1.5 cm in upper left pole. There is no gonad seen in abdominal or inguinal region. Uterus-like structure seen in pelvic cavity. We have done 2D echo, dilated IVC, small PFO 2 mm, and small muscular USD present. There is no PADA. So we do full fluid restriction done with urine output monitoring. Respiration improves, so patient shifted to nasal prongs. We monitor the urine output gradually, monitor urine output and the serum create and urea, which was gradually increasing trends. Urine output procedurally less than 0.5 ml per kg per hour for 6 days. IVC was dilated, so restricted fluid continue and D5 half an continue. There is no ECG change in no ECG changes of in electrolyte potassium was 6.9 higher level, but there is no ECG changes. We give bicarbonate given. Relative action about the condition with requirement of the higher central plan, but relative was denied. We planned dialysis. Dialysis was planned for further deterioration. On 9 days of life, gradual feed was started. Urine output improved 1.5 ml per kg per hour. Vitals, patient last 4 days, febrile, no tachypnea, no distress. CRT less than 3 seconds. SpO2 maintaining on room air 19%. Mean BP was 62 mmHg. Serum create and urea also gradually decreasing trends, and sodium potassium also improving. We sent karyotyping, and reports came 46xx. Summary: a full-term child born at 39 weeks admitted in NICU for respiratory distress and abnormal genitalia, treated for mechanoaspiration syndrome, early onset sepsis, having clinical impression of multicystic dysplastic kidney with acute kidney injury, and ambiguous genitalia, suspecting having CH, simple villaging form, due to the 21 hydroxylase deficiency.
So is the child is on any glucocorticoid or mineralocorticoid supplements right now?
No, sir, not right now. Because 17
Hello?
very. Hello.
Not right now. Okay, fine.
Hello.
So is this yes, yes.
No, sir, patient is not on any
Hello?
glucocorticoid. Hello. Sir, are we audible?
Hello?
Hello.
Yes, 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 please go ahead.
Yes, sir. Patient is not on any
Yes,
glucocorticoid.
yes. Right now you are audible. Yes, you can say.
Okay, sir. No medication started, sir.
Oh, okay, fine. So what is the important point which is going against congenital adrenal hyperplasia in your workup? Can you tell one particular investigation which is going against CAH?
Sodium level. There should be hyponatremia.
Yes, yes. So renal failure as well as adrenal failure, both there will be hyponatremia with hyperkalemia. And
Yes.
in this case, the sodium is continuously rising. So one thing,
Yes.
this is not in the favor of congenital adrenal hyperplasia, number one. Number second point is this is not simple virilizing a form of CAH, if at all it is CAH, because at birth it presents with ambiguous genitalia, number one. So it is called as salt wasting
Yes.
CAH, not the simple virilizing. Simple virilizing will be normal at birth, and after some time they will have virilizing features in which the enzyme deficiency is approximately 1%. So they will be normal. There is no salt wasting crisis, though this child is much more than just the salt wasting crisis. So we cannot define particularly salt wasting crisis. But still, have you done cortisol level or aldosterone level or anything like that?
No, sir, we have planned, not done yet. We were waiting for karyotyping report.
Yes. So I think this. Okay, fine. So your first impression is very clear. I mean, so first of all, any atypical genitalia, number one, I would be giving few suggestions. Like in your first slide, you should be mentioning the complaint in which you have not mentioned the complaint, right? So a
Yes.
case of full-term newborn presenting on first hour of life with atypical genitalia.
Yes.
Okay, and nowadays the word should be atypical genitalia, not the ambiguous genitalia. Okay, some might be offended. So nowadays the word is changed to atypical genitalia. So any newborn with atypical genitalia, at first you would like to examine for the gonads, right? So palpable gonads, if at all present, they are most likely to be testis because ovaries won't come down to palpable things. So two things you should be looking. One is palpable gonads and second is ultrasound. Third, of course, karyotype. So by this too, you can probably decide the gender of the child, which is a social emergency in our scenario. So with this too, you can say that mota gender is this. So of course, you should not use the word like baby boy or baby girl, but you can say ki the gender is going towards male or female, but we should be waiting till the karyotype arrives. Number one. Number two, there are many other causes of XXDSD apart from this. So have you asked anything regarding maternal virilization or something? Do you know what is maternal virilization and how it is correlated with the ambiguous genitalia or atypical genitalia?
Yes, sir. If we have examined for maternal
Hello?
virilization. Hello.
Hello?
Hello. Hello.
I think voice is not properly heard.
No,
Sir.
I am able to hear you, Mitesh.
Yes.
Yes.
You can continue.
Hello?
Hello.
You can continue. I am able to hear you.
I
Okay.
think problem is on
Dr. Chetan, are you able to hear? Hello.
Hello.
Hello?
I am also able to hear both.
I don't know whether there is Wi-Fi issue on my side or on your side. Uh,
Are you able to listen, Chetan, now?
Dr. Chetan, are you able to listen?
Not now.
Hello.
Uh, Chetan, are you able to hear us? We are able to hear both the sides.
No, I am clearly able to hear you, but I am not able to hear the presenters.
Hello.
Sir, are we audible now?
Yes, now you're audible.
We
So the thing I was
examine
telling that, yes.
we examine, sir, mother for aromatase enzyme deficiency or PET 24 450 peroxidase enzyme deficiency and leukeloma of pregnancy, sir.
So how did you examine for the aromatase deficiency?
Sir, if there is virilization in mother present and also in
Yes.
baby, then there may be aromatase deficiency.
Yes. So that's a point regarding the history that you should specifically ask if there is any voice change or hair growth at abnormal place like beard around the umbilicus or inner part of thigh or lower back. This will directly hint towards the aromatase deficiency, and which can be present similarly as the our salt wasting CAH. So this thing. Number three, I would like to comment that the 17-hydroxyprogesterone should be done after 72 hours, which is perfectly fine. But in case of stress, 17-OHP and cortisol might be elevated. Like in this case, the baby is on high frequency nasal cannula and all. So baby is definitely in stress. So in stress, 17-OHP can be elevated as well. So if you would have done 17-OHP along with the cortisol level, then low cortisol with high 17-OHP will suggest definitely there is some enzyme defect. So a cortisol level will definitely help in this case when there is no hyponatremia. So if cortisol level would be low, then definitely we are justified in starting the hydrocort on the first go as well. But because there is no hyponatremia and we don't have any genetic thing till now, we are in dilemma whether it is 21 hydroxylase or any other virilizing CH or any other genetic defect leading to the similar, you can say, clinical picture. Third thing I would like to mention is 3-beta HSD deficiency. In 3-beta HSD deficiency, though 17-OHP is not so much elevated, but still it may be a possibility. So how are you planning to go further?
Sir, now karyotyping report came, so we will like to do. There is a 17 OHP, repeat 17 OHP, and if it is borderline, then we will do ACTH stimulation test.
Okay, fine. You can do ACTH stimulation test definitely, but that might be a confusing because of the stress and this renal issue and all. The baby might not react well to ACTH stimulation as well.
Sir,
Sir,
now
at present, sir, patient is on room air.
Yes,
And
good.
full breastfeeding.
Breastfeeding, sir.
And
Okay, I
sodium is
think
also.
what is the last creatinine?
Sir, last creatinine is 2.9.
2.9. Okay,
Yes, sir,
fine.
almost
Fine.
normal.
Okay, fine. So ACTH stimulation test definitely you can do, but still I would recommend to go for genetic testing as well
Okay.
for the 21 hydroxylase gene, and that will help in define the overall prognosis and long-term supplementation of glucocorticoid as well as fludrocortisone as well. So though looking like CAH, but maybe it turn out to be other genetic deficiency as well. So uh, this is the dilemma, and I think genetic diagnosis would help. Of course, it's a institute level patient, so maybe affordability or I don't know what is the procedure there, but definitely if at all you guys can send genetic, that will be the most helpful thing in this kind of case. And the baby is stable. Baby is not increasing in pigmentation, right?
Yes, sir.
No,
No,
sir.
sir.
No
No.
pigment.
So that is also going against CH. Though pigmentation typically starts after 2 weeks, 3 weeks of age. But still, if you increase in the pigmentation, that will also directly point towards the cortisol deficiency. One thing you can do, if further sodium falls below 135, then you can do paired cortisol and ACTH without any stimulation. See, ACTH is high, then you don't need to go for ACTH stimulation because ACTH is already high. And with high ACTH, if your cortisol is below 5, then it is indirectly suggestive of cortisol deficiency. So this is another practical thing which you can do while monitoring the sodium level as well. If there are any features of persistent vomiting, not gaining weight on full breastfeeding and full room air, then definitely this is also a sign of salt wasting crisis, or you can say failure to thrive. In all this, we are justified in starting the hydrocortisone on the first go. Mineralocorticoid plus minus. Suppose if at all you want to start hydrocortisone, at what dose do you give hydrocortisone?
10 to 15 microgram per mg per kg per meter square, sir, per day.
Okay. So initially baby is in crisis. So maybe we'll start with the higher dose of 20 to 25 milligram per meter square. And then depending on the 17 OHP level, we'll adjust the dose. But initially you should be starting with the higher dose. And then what you say 10 to 15 is the normal dose for CH. But initially you should start with the higher dose and then depending on the 17 OHP level. Another question is what is the target of your 17 OHP while you treat with hydrocortisone and fluorocortisone? See, we know normal value less than 1, maybe less than 2.
Yes, less
right?
than, yes.
But what is the 17 OHP target? So what is the target while you treat the CH patient in general?
We will do, we will monitor for height and weight of the patient.
Okay, fine.
If height
So
is,
see, that is fine, but you will have to do frequent 17 OHP measurement along with the sodium and potassium, right? So
yes,
what is the 17 OHP level you will be satisfied with while you treat with Hyson and Fluoricort?
less than 2 nanogram per ml.
Okay, fine. So here is the catch. Because we are giving steroid from outside, we should be monitoring for growth as well. If the steroid will be there in excess, the growth will be hampered along with the chances of obesity and all, right? So we don't want that as well. So we want a proper growth along with a proper control of the 17 OHP. So we'll target 17 OHP in upper higher, that is between 2 to 8, maybe 2 to 10. So typically we want to maintain 17 OHP between 5 to 7 as well, so that we should not be giving excess of hydrocort as well as fluoricort, right? So it is not that we should maintain below 1 or below 2. A little bit of higher is fine because we have to see the growth as well. Number 2, suppose if the what you can say, if your 17 OHP dose, if your cortisol dose requirement is higher, say the baby is requiring 18 to 20 milligram per meter square. What are the things you would look why the baby is needing high dose? Any other thing you would like to see?
Baby requiring
Hello?
higher dose.
Yes.
Hello?
Yeah. Now you're audible. So my point is, if the cortisol requirement goes above 15 milligram per meter square, you should be looking at plasma renin activity as well, because fluorocort deficiency will indirectly lead to volume depletion, and that will lead to high 17 OHP due to stress. Okay, so many times it happens we are increasing the Hyson hydrocort dose, but we are not thinking regarding the fluorocort dose. So definitely, if your 17 OHP is higher, despite having higher dose of Hyson, you should be thinking of mineralocorticoid axis as well. And maybe you can go for PRA. If your plasma renin activity is high, then you can increase the dose of fluorocort, and that will bring the 17 OHP down indirectly. So these are the clinical pointers you should be looking while managing the CAH. Fine. So in this case, my comment will be to go for the genetic testing. If at all you feel the baby is going into failure to thrive part, or sodium is going below 135, then again we can do repeat 17 OHP, because this 17 OHP was of 72 hours. And then if still is about 10, then we can directly start the hydrocort as well as fluorocortisone, because anyway potassium is higher. Might be due to renal component, but that might be due to mineral cord deficiency as well.
Yes.
Okay, fine. So any other points or inputs from your side? Any other questions you want to ask?
Sir, any child, maybe there is any syndrome associated with polycystic kidney disease and ambiguous genitalia. Child is also having VSD, although not any significant, but 2 to 3 millimeter VSD is there.
So
So
21
parent,
hydroxylase gene is on 6th chromosome as far as I remember. So I don't remember such kind of syndrome which involves these three anomalies. One important gene is Wilms tumor gene, WT1 gene, which will cause Wilms tumor on the follow-up,
WT1 gene.
but that is XY-DSD, not the XX-DSD, right?
Okay.
So maybe if you go for the clinical exome sequencing or whole genome, then they might found some another gene as well, but it is not known. Yes.
Okay, sir. Uh,
And
sir,
don't forget to go for that eye and retina as well as the hearing defect, if at all, because it's a kidney issue. So do BERA as well as your uh, retina and all screening while you discharge or whatever your protocol is.
and sir, should we start treatment hydrocortisone and fludrocortisone in this patient, or we have to repeat and then we will
Yes.
start?
So my take will be you should repeat 17 OHP sodium potassium, right? Because currently baby
Yes.
is not in salt wasting crisis. Salt wasting crisis develops after 3 weeks of life, right? So if you have documented low cortisol with high ACTH number one or persistent high 17 OHP with hyponatremia, then and then you can start the hydrocort. Otherwise, there is no need, because if you once start hydrocort, it will confuse your diagnosis. So if at all there is no issue in weight gain, no issue in urine output, then maybe you can wait till the diagnosis is gets established. Okay. So Dr. Kunal, any other perspective from the neonatological side?
Not anything from my side right now. So
I think it's a good case, but only genetic thing will help in differentiate whether it is 21 or any other defect.
There should be one slide regarding the counseling. I think that is a must needed part as far as in government setup, also in the PG. Generally, when I face this kind of cases in our PG, always we are in doubt what we should counsel and what would be the outcome and everything. So any thoughts on that one?
Yes, definitely counseling is must whenever we are in dilemma regarding the gender. As I described earlier, then we should not be going to disclose gender early until the karyotype comes. Even if karyotype is typically XX or XY, there are few syndromes in which the gender of rearing is opposite as compared to the karyotype. So definitely, till karyotype, we should be using the words badak, wherever, not babo or baby, or maybe you can say babu, and always use what you can say નાન્યતર જાતિ. બાળક આવ્યું છે, બાળક આમ છે, બાળક આવી છે કે બાળક આવો છે એવું બી I think we should not tell, and we should be telling them that this is a very important thing, and it will decide the whole gender of rearing and future of your child. So maybe we can counsel them that you should not tell any other thing specific regarding the issues of child to your relatives particularly, because the main issue arrives when relatives know that the child is of atypical genitalia. So, and everyday counsel regarding gender of rearing, each and every counseling you should mention that till date we cannot say the gender of rearing exactly. You should wait. This should be included in each and every day counseling because relatives are eager to disclose the gender of the child to relatives and maybe many other people. So each and every day you should discuss regarding the gender of child, and you should not be doing or counseling percentage wise, like we feel 90% this is male or 80% this is female. So there is no such thing like percentage, right? So these are all things you should avoid because nowadays it is of medical legal importance as well. So you should you should tell the non-specific words like બાળક મોટા ભાગે આવું હોઈ શકે છે એવું બી નહીં use કરવાનો કે બાળક મોટા ભાગે જેમ કે if this is the case that બાળક મોટા ભાગે બેબી જેવું લાગે છે હોઈ શકે કારણ કે એમાં ગોળી નથી અને એના રંગસૂત્ર આવા આવા છે. So this kind of language you should use while you counseling the parents. And you should ask the parents because many times it happens that every day different relative comes and they ask the same question or the same question in very different language. Then you should be strict about that what persons you will be talking to daily, so that you should also be strict while counseling part is happening. I think this is all regarding counseling.
ACTH stimulation કરાવી રિપોર્ટ કરી દો તો ચાલે કે પછી કોર્ટિસોલ અને ફરી પછી 17 OHP રિપીટ
see પહેલા તો repeat 17 OHP જ કરવો પડે. ACTH simulation test, what are you want to find out that how much is 17 OHP rises. For that as well you need 17 OHP basal. So my point is first you go for basal 17 OHP maybe along with that cortisol and ACTH. So that will be like clearing the picture. You might not need the ACTH stimulation test as well. Number two, we don't have that synecthin, which is synthetic ACTH right now in Gujarat and probably in India as well. So we are doing as a long-acting ACTH that is called actin prolongatin, right? For the actin prolongatin test, the cutoff for 17 OHP is not that clear as compared to synecthin. So again, you will be in dilemma if you do actin test, because actin test is only for adrenal insufficiency measuring cortisol. So again, you will be, I mean, જેને કહેવાય ને ઉલમાંથી ચૂલમાં પડશો. So definitely ACTH stimulation test will be difficult to do. Okay. Any other thing, Dr. Vishal, you want to add regarding counseling?
No, that's great. That's generally we all face in our PGs.
Yes.
So that we want to stimulate them and documentation and everything, daily counseling. And
Yes. So each and every day, including seniors and all, should be have same findings regarding the genitalia and stretch phallic length. You should be writing stretch phallic length. You should use the word phallus, not the penis. So no stretch penile length. Okay, stretch phallic length. Even you should not mention clitoris. Okay, only phallus. Phallus is 1 centimeter or 10 mm, not the clitoris, because we don't know whether it is clitoris, hypertrophied, or penis, which is atrophied. Right? So only phallus and only gonads. No testes, no ovaries, nothing like that. Those words.
okay, just one question from my side, Dr. Chetan. What's your thought about the reconstruction surgery? Like if any baby have a genitalia, and what age and what would be the criteria for the reconstructive surgery?
Yes, so that's a very good question, and guidelines are constantly changing regarding the reconstructive surgery. Earlier, the dictum was that at 1 year, it should be going for the first surgery, baby should be going in which clitoral reduction is the surgery, and then after that, if at all reconstructive surgery is needed at 4 or 5 years of life. But nowadays, because we know that the clitoris is full of nerve endings that might be acting as a pleasure in the physical activities as well. So right now, the dictum is that let the patient decide. Let not parents decide. So whenever patient is turning 14, 15, 16, at that time, the patient, that female thinks that I want my clitoris to get reduced, then and then you should go for the clitoral reduction. Otherwise, earlier 1.5 year clitoroplasty, then vaginoplasty, nowadays it is not indicated at all. And many times it happens during first 1 or 2 years, the clitoris will be normalized whenever we have androgen or testosterone suppression. So nowadays, at 14, 15, 16 years of age, these all reconstructive surgeries are recommended. Till that time, no parent should decide the child's look of the, you can say, vagina or clitoris. So this is the newer thing which is upcoming, which is followed. When I was in UK, it was the same guideline. But many times it happens that many surgeons do clitoroplasty at 1.5 year, but nowadays it should not be done. So that is clear.
Great. Yeah.
Yes.
I have a question.
Yes.
Hello,
Yes, yes, I can hear you.
Dr. Chetan, Dr. Charul over here.
Yes, ma'am.
When we were studying, during our residency days, there was a dictum that except for 5-alpha hydroxylase, all the babies born with DSD should be reared as female. So that dictum stands true, or it is now no more applicable?
See, first of all, it depends on XX or XY, right? All excess XX DSD should be raised as female. That is not an issue. But in XY, if it is associated with complete androgen insufficiency, CIAS, on those cases, you should be raising them as female, because anyway testosterone will not help.
Yes.
So all XY except CAIS, complete androgen insufficiency, they should be raised as male, and all XS probably raising as female. Those with mixed gonadal dysgenesis or having mosaicism with XX and XY both line, that will be individualized, whether they have testes or whether they have ovary, depending on that, as well as phallic length. So all XX female, all XY except CAIS male. That is the dictum nowadays. I mean, this is same. So 5-alpha reductase will be XY. We can call it Shikhandi syndrome as well. So 5-alpha should be raised as male. There is no confusion. Also partial androgen male. So 5-alpha partial all male. Yes.
Thank you.
Charulven, I think with the consent of Chetan, I can say that in older times they used to tell this simply because if you say that the baby might be female, then it would be really easy for parents, because in the future life also converting a or making a male from a female was a difficult reconstructive surgery and difficult rearing issues also. So if they have told them that it is probably a female, then it works out on the longer run. That was probably the idea behind that.
Okay.
But I would like to add a point that, yes, see, what is 5-alpha reductase? The testo is not converted to DHT, right? And DHT is the main hormone responsible for the all external appearance, like growing of beard, growing of mustaches,
Secondary sexual
development
characters.
of penis. So what happens when there is 5-alpha? The boy is born with atypical genitalia. But whenever this boy is going into puberty, there is huge production of testosterone. Though it is not been able to convert to DHT, but that testosterone can act locally, and that will have normal penile growth. So if you think of Shikhandi was born as female, reared as female, but during puberty he was converted to male. So probably Shikhandi might have 5-alpha reductase. So it is better to raise 5-alpha as male, because anyway they will be virile because they have abundance of testosterone, plus there is no defect in receptor as well. There is only defect in DHT formation. So 5-alpha also should be raised as male as well.
True, very true.
Yes.
પણ જૂના સમયમાં શું છે કે એ સમયમાં રિકન્સ્ટ્રક્ટિવ સર્જરી એટલી આગળ નહોતી
Yes.
હોતી,
Noti,
એન્ડોક્રાઇનોલોજી
right,
એટલું
right.
આગળ નહોતું, એટલે
Right.
એ જમાનામાં વધારે ડિસિઝન મેકિંગ કોમન સેન્સ થી લેવાતા હતા.
Right.
That was
Sort
the
of.
reason probably this was made a dictum in longer
Dictum.
run.
Right. And nowadays we have very good reconstructive surgeons are also available. So nowadays it is going fine. Even pediatric surgeons do good reconstructive surgeries. If we talk about Rajkot or Ahmedabad, maybe in Jamnagar as well. Yes. Any other thing, Dr. Kunal?
I think we can wrap up now. If there are no more questions, then we can wrap up.
Okay.
So, thank you so much, Dr. Mitesh and colleagues, for the wonderful case presentation. Dr. Maulik for excellently mentoring them. Dr. Chetan for asking such interesting questions. Dr. Charul and Dr. Vishal adding their expertise. So, thank you all. Thank you, Dr. Arshad, for being there with us. So, thank you all. Thank you, ClearNet, for the seamless experience. I would thank you one and all. Ritu, we can close now this session.
Congratulations. It was good, really.
Thank you.
Yes.
Ritu Parna, are you there? Ritu? So I think we all can log out now. Thank you so much. Thank you all.
So thank you everyone for your wonderful presentation and lucid explanation. I hope you had a seamless experience. So with all the information, we are signing off for today. Hoping to meet you again in another interactive session in the near future. Till then, stay safe and healthy and have a nice day. Goodbye to all.